Hi, everybody. So I've got an opportunity to assess another ECG today, and I hope you all will enjoy. This is just our introductory screen that we have every week, or whenever we do this. This week's case is a 71-year-old woman with syncope. So whenever you get an elderly person with syncope, there's a few things that you have to consider. Number one is cardiac. Number two is pulmonary. Number three is what you call it, CNS. And then the other thing that we also have to consider most of the time in the emergency department is also thrombotic disease and valvular disease as well. So these are all the things that we consider. So when we look at cardiac, we look at rhythm disturbances, and we look at valvular insufficiency, specifically aortic valve stenosis, right, which often presents with syncope, anginal pain, and dyspnea as well. So there's quite a few things that you have to consider. There are others as well, but that's the most common one that you'll see. You can also have it in aortic regurg, but it's not as severe. So that can sometimes be related to the high systolic pressures that they experience, and you can sometimes get transient ischemic attacks, but it's not very common. It's more with the aortic stenosis. Then when you're looking at pulmonary, you're looking at pulmonary emboli, mainly hypoxia. You can even look at non-exertional heat stroke in the hot months. Then, of course, we look at central nervous system, which is transient ischemic attacks, where you've got to look for vessel narrowing and things like that. And one of the often overlooked ones is thrombotic disease of the carotids, or further. So the most common one that you can see is the common carotid in the neck, but even further up in the carotid tree, if you've got any thrombi that are lying around over there, or any sort of atherosclerotic disease as well, that can often result in syncope on a regular basis as well. So there's also vertigo, but generally the patient would have had a vertigo attack prior to that, and it has to be quite severe to induce syncope. And then, of course, you have vasovagal and orthostatic syncope as well. So as the patient sees something that elicits a vasovagal response, or orthostatic, if they get up very quickly or move from one position to another, especially in the elderly, and it's normally associated with CCF and LVA, left ventricular failure and things like that, and they can also have it. But generally, your approach to a patient when they come in would be to have a look at the central nervous system, have a look at the pulmonary system, the carotids, and then you would go to the cardiac. And of course, your ECG forms part of your cardiac. So that's how you would approach an elderly person with syncope. And in fact, most patients with syncope, that's how you would approach them and see how they're doing. Okay, so let's get on to the ECG itself, and hopefully we can learn something from them. So we have a 71-year-old woman with syncope. That's all we know. And all they've done is given us the rhythm strip. That's it, nothing else. Because this is actually what we have to concentrate on in this one, is the rhythm. So we assume that there's no ischemia, there's nothing else that's going on. And you can see they've done a long rhythm strip, so it's running over quite some time. So let's have a look. First, let's start with our analysis, like how we normally have a look, where we look at our P waves. So what you'll notice is that we have normal morphology of the P waves. The P waves themselves look fine. All right. And then we come to the interesting bit, which is what I want you guys to actually have a look at. And it's what the main focus of this lecture is today. And that's the PR interval. So let's have a look. So when we start off here, if we cover the others, we see we have, we'll get to them next, no problem. So we have 1, 2, 3, 3.5, let's say 4. So it's within norm. So that's our first beat. Once we get to our second beat, we see it elongates. We've got 1, 2, 3, 4, 5. So now it's starting to get longer. When we get to the third one, 1, 2, 3, 4, 5, 6, 7. So it's become extremely long. And then we see a P wave with no QRS complex. And then we see the rhythm repeat itself again. We've got short, longer, longer, drop. Short, longer, well, I suppose it's missed there, longer, longer, drop. Short, longer, longer, and drop. Short, longer, longer, and drop. So this is a rhythm disturbance. So it's a cardiac block. Right? So we only have 4. that we need to worry about. Now, there's type 1, right, or a first degree heart block, which is where your PR interval is elongated. All right, so it's obviously not that. It's not just elongated. Then we have Mobitz type 1 and Mobitz type 2, all right, or the Wenkelbach blocks. All right, and we're going to discuss the difference between them now. And then you have a total or third degree heart block where there's no relationship between the P waves and the QRS complexes. So the first thing is in a complete heart block, because there's no relationship between the P waves and the QRS complexes tend to be wide. So that normally, once you get thin complexes, you can sort of rule out a complete heart block. So that's when we get to the interesting part, which is where a lot of people get mixed up, and they often forget which one is which. So what I can tell you is that as a general rule, not always, Mobitz type 2 generally has slightly widened complexes. And in this one here, we can see we've got thin complexes. Okay. So once you start seeing thin complexes, your mind should immediately start thinking about Mobitz type 1. But the thing is with Mobitz type 1, what happens is that you get these PR intervals that are slowly elongating. All right. And as they elongate, they eventually drop. So you can have, like, this is a 3-to-1 drop. You can sometimes have 4, even 5, 2. Sometimes it is quite difficult once you start getting to the 2s and that, so to make it out. But this is the most common one, which is 3-to-1. You know, where you see the elongation, and eventually the drop. Elongation, and eventually the drop. All right. So what's happening here is that there is basically an interference that's occurring between the atrium and the ventricle. So what happens is that it's taking longer and longer for the atrium to then send its signal, or the SA node to send its signal through to the AV node. So it's being delayed. Now, the most common cause of this is structural damage, right, to the conducting cell. Right? So ischemia is a common cause, direct structural damage as well. Channelopathies can also cause it, but the most common cause would be structural damage. So direct trauma to the heart, such as ischemia and things like that. So that's when you start getting this. And then eventually you start getting the point where the wave is not conducted at all. And then again, it starts getting conducted in this way as well. Now, the truth is that the majority of these patients will develop symptoms such as syncope, palpitations. If they start getting into into a tachyarrhythmia and things like that, they can eventually progress now to Mobitz type 2 and complete heart block. So that's where the issue comes about. And sometimes they do need, what you call it, the electrophysiologist to have a look at them and see what's going on. So like I say, the PR interval that's slowly lengthening, that's what you're looking for in a Mobitz type 1. All right. So this is what we have here. So here we have sinus rhythm. All right. So they say it's sinus rhythm because what you call it, P waves are always present, right? So that's why they consider it a sinus rhythm with within a second degree AV block type 1, right? So Wenkelbach or Mobitz type 1 at a rate of 60. So the P waves are constant and are noted preceding each QRS complex, right? However, some P waves are non-conductive and instead followed by a pause. The PR intervals demonstrate gradual elongation before each non-conductive P wave. This pattern is typical of sinus rhythm with second degree AV block type 1, also known as Wenkelbach or Mobitz 1 AV conduction. All right, so let's move to what they have. All right, so this is what the explanation of it continues. So as you observe the relationship between P wave and QRS complex, characterized by progressively longer PR intervals with ultimate drop beat, as noted by the arrow, no QRS complex. Right? The QRS complex is narrow, group beating or clustering of QRS complexes is seen as well. Right? So once you see it, then it's quite easy to actually make it out. So once you have this elongated PR and a drop, that's a second degree or a Mobitz type 1. So the question would be, what about a Mobitz type 2? How do you have a look at that? Right, so here's a Mobitz type 1 versus Mobitz type 2. So first, let's look at a normal rhythm strip. So you have consistent PR intervals followed by narrow QRS complex. So you have a normal P wave, normal PR interval followed by a thin QRS complex. a QRS complex follows every P, and then those groups are all regular. All right, so that's what a normal heart rhythm strip should look like. All right? So Mobitz type 1, you have a PR interval, you have normal P waves, all right? You have thin QRS complexes, you have PR intervals that are slowly elongating, all right? And eventually you get a QRS that's not conducted. So it can never be regular. It's never a regular rhythm. And even physically, when you check the patient, you'll see that there's no, what you call it, it's a regular, irregular rhythm. So that's what you feel when you feel the pulsation. So you feel 1, 2, 3, a gap. 1, 2, 3, and a gap. 1, 2, 3, and a gap. Or 1, 2, 3, 4, and a gap, and things like that. So it's a regular, irregular pulse. Okay, and then you get to a Mobitz type 2. So it also has normal morphology of P waves. Even in a third degree heart block, there's normal morphology of P waves. But here what you can see is that the PR interval is normal. The QRS complex is also generally thinner. Sometimes they can be a bit wider as well, just depending on the amount of what you call it, conduction abnormality that's going on over there. Okay, so what happens is you have this consistent PR interval, and generally it's elongated. Now in this one here, it doesn't look too elongated, but generally tends to be slightly elongated, with the difference being that eventually you get to a non-conductive. Right? So it's generally irregular, but you can have irregular as well, but much less commonly. All right, so the more commonly is to have like 1, 2, or 3, and then a drop, 1, 2, and 3, and then a drop, just like how you would get here. Okay, so I hope that makes it a bit easier for everybody to understand. Apologies, it is a bit of a short presentation this week, not the longest we've ever done, but I thought it was important for everybody to know. And yeah, listen, if there's any questions or anything like that that anybody would like to know, more than welcome to message me just to find out. That's just a little joke to finish off. So these rhythms are often overlooked. It can be easy to concentrate on the central nervous system, but don't forget that your brain needs blood. So blood is supplied by the cardiovascular system. So always remember to have a look at that before you decide to just say that it's a TIA or it's just vasovagal. All of these patients deserve an ECG. Even in a younger patient, they do deserve an ECG, because it's not necessarily that it's always what you call ischemic related. There's cardiac bridging, there's channelopathies, there's what you call congenital conductive disorders. There's so much that can actually cause all of this. Tumor as well, quite commonly, more common in the younger patients, infections as well. So, these are all things that you have to look at. So always remember, whenever you have one of these patients that presents with syncope, especially if it's regular syncope, they tend to complain of having this at the most inopportune times, or it may be related to certain things, for example, especially in the younger patients who generally have better reserves, they may notice it during times of physical exertion, emotional exertion, and they have the syncope that's happening. Now, there's a lot of patients where it is just vasovagal. It's not related to anything physical, or it's psychosomatic, whatever it is, but you still owe them at least an ECG, at least the basic blood test to do a proper examination of the carotids and of the respiratory system, and also, to do a proper CNS exam just to make sure that there's nothing else that's going on. Look for a history of medications as well. There are certain medications that precipitate these arrhythmias as well. Beta blocker is one that comes to mind, calcium channel blockers as well. You do get certain antidepressants, which are more common, unfortunately, now, even amongst our younger patients, I'm just trying to think of some of the others that are also used, autoimmune regulators. There's quite a few that can lead to all of these issues, So, it's always good to have a drug history as well. Trauma is also another one that's commonly overlooked, So direct trauma to the heart, previous MVAs, falls, injuries to the chest, things like that are also things that can surprisingly lead to this. Not as common, but it can lead to, especially in a younger patient, somebody may have been involved in a high-speed MVA, may have even, been admitted, been there, cardiac, everything was fine, and now it's, they normally present now quite some time later, ongoing syncope, things like that. And because of, the history of, they would often rush to look for chronic subdurals and things like that, but we often may overlook the cardiac. So it's difficult in an emergency setting, but just so that you understand there is this possibility that it can happen. Okay, so yeah, I hope you guys enjoy that, and yeah, hopefully learn something from there as well. Okay, thanks everybody. Keep well. Bye.